live. Nice. Fix this. Vitamins 144. Why?
Glucocorticoids, we just finished. Chapter 7, we'll check the steroids themselves, glucocorticoids. Now, when you look at glucocorticoids, they're all derivatives of cortisol. And as derivatives of cortisol, you may want to remember one thing that sometimes is not obvious in physiology. Cortisol as a hormone produced by the adrenal cortex not only binds to cortisol receptor, it's a full agonist, so if you want it has an efficacy of 1, and it also binds to aldosterone receptor. Therefore, cortisol also has mineralocorticoid activity. Well, of course, we don't plan on using cortisol itself, but modified formulas of cortisol in order to have a better pharmacokinetic. As an endogenous hormone, its effect would be far too short-acting. Well, there's many cortisol type of sound out there, like cortisone that you can find over the counter, or prednisone, for instance. Notice that as soon as chemists make modification on the structure, what they try and do is maximize the glucocorticoid activity and minimize the mineralocorticoid effect, the aldosterone-like effect. Prednisone is available over the counter in ointments, but also available as prescription concentration, or prescription doses, I should say, particularly in transplant rejection. It is of medium duration. Having still aldosterone effect, it does mean that these derivatives of cortisol could cause salt and water retention. Triamcinolone is 5 times more potent than cortisol and is avoiding the aldosterone receptor. And maybe some of the bigger ones to know would be beta and dexamethasone, which are several-fold more potent than cortisol. Look at this. Dexamethasone is the most potent of all the steroids. Remember, as we used it in physiology for the dexamethasone suppression test, we actually were trying to differentiate ACTH production by the pituitary in Cushing disease, which would be suppressed by the actual high dose of exogenous steroid, from that of ectopic production of ACTH, such as in paraneoplastic syndromes of bronchogenic or renal cell cancers. These would fail to respond to the test. So when I'm looking at those, does the table represent all of the steroids that are out there? Well, you know, I'm really there kidding you, because overall there are literally dozens of molecules that are steroids. So knowing these is just to give you a little idea of some steroids out there. They all share the same mechanism and the same side effects. Mechanism-wise, 2 ways for your board to test you. The pathological way is to test you with a cellular effect through changes in gene expression of these molecules. They change the gene expression particularly of integrins. Integrins are required for the sticking of white blood cells to the endothelial wall. And integrins, you might remember from immunopathology, are part of the immunoglobulin family. The decreased gene expression of integrins then will result in decreased adhesion and therefore decreased leukocyte migration. Otherwise, steroids are known to increase lysosomal membrane stability, and that means a decreased phagocytosis with decreased fusion of lysosomes with endosomes, and a decreased capillary permeability. These are directly affecting the process of inflammation. Notice we did not boldface type them, although I know that sometimes your boards will want the story of integrins for 1 clinical point. Can you tell me what would be the white blood cell count of a patient on a steroid? I'm hoping you're telling me you would find an absolute leukocytosis because of a defect in adhesion. So knowing that they decrease integrin gene expression is definitely testable. Rather, for the pharmacological effect, we like to go through the biochemistry. And as we've seen in the chapter on prostaglandins, the biochemical action are primarily that of inhibiting phospholipase A2, the enzyme responsible for breaking down arachidonic acid in prostaglandins and leukotrienes. So it's kind of the biggest drug that we have really on that system. Now, because it works through gene expression, you may want to remember that it's not that the cortisol-like compound binds to phospholipase A2 to inhibit it, but rather it controls the gene expression of lipocortin, and it's lipocortin in turn that shuts down phospholipase A2 and prostaglandin and leukotriene production. Other important proteins that are under the control of steroids. The expression of cyclooxygenase 2 is itself inhibited by the steroid, as well as important platelet activating factor, which participates not only in thrombosis, but also in inflammatory responses. Interleukins, like interleukin 2, an important mediator of stimulation of lymphocytes, is also going to be interfered upon in its expression. Well, thanks to all this, steroids are both anti-inflammatory and immunosuppressive. And let me summarize that whole page with 2 points. Know that steroids decrease gene expression of integrins and cause an adhesion defect, and know that they block phospholipase A2, and the blockade results in lack of prostaglandins and leukotriene. Well, the side effects are literally the endocrine physio of cortisol, except you're looking at giving high doses of a cortisol-like substance, which should result in iatrogenic, meaning drug-induced, Cushing type of syndrome. Well, we know how to describe a Cushing syndrome, but before I do so, by giving exogenous steroids, you are basically doing a dexamethasone suppression test in your patient when you treat them with these anti-inflammatory drugs. It means the exogenous steroid you're giving will cause suppression of ACTH. This is a very important point to remember. If you stay more than 4 to 5 days on a steroid, the significant ACTH suppression will result in an adrenal hypoplasia. That is, if you suddenly remove that steroid, your patient has no endogenous cortisol, no endogenous aldosterone to have permissive action on the cardiovascular system and hemodynamics. You know what it means? It means a sudden withdrawal of chronic steroid therapy will result in shock and potentially kill the patient. So in your margin, notice how we tell you to always taper the dose of a steroid prior to stopping the administration of these drugs. And don't forget, you don't need to be on steroids for years to be considered under chronic steroid therapy. On to the iatrogenic Cushingoid syndrome there. Well, what do we expect that patient would look like? I'm sure you can describe to me someone with overweight situation, particularly some nice truncal obesity. Remember the buffalo hump that these people develop? And as far as other external features, the potential for purple striae along the abdomen from the stretching from the fat overload, but also the thinning of the skin, since we have lots of proteolysis. That's because of the biochemistry of increasing gluconeogenesis and causing hyperglycemia. 2 points here on your boards. The fact that corticosteroid induce the enzyme PPCK, which is one of the controlled enzymes of gluconeogenesis, and the fact that the hyperglycemia means caution if your patient is a diabetic. So caution in a diabetic. What else could we say? Cortisol causes increased osteoclastic activity. Osteoporosis is a problem in chronic steroid therapy. There are no ways of chronically administering steroids without suffering osteoporosis. They try to minimize this with alternate day therapy, where you take steroids one day, don't take it the day after, take it again, or by changing the dosing depending on the day. None of these type of dosing have resulted in decreased osteoporosis. Worry about this, particularly in the elderly. The lack of prostaglandin will cause increased gastrointestinal acid, and as such the risk of ulcer is just as big with steroids than it is with aspirin-like drug, particularly here because of the proteolysis and the thinning of tissues. Well, you can actually have perforation more likely with a steroid than you would with an NSAID. And if it's a steroid that doesn't avoid the aldosterone receptors, then salt and water retention would result in edema, bloating, and hypertension in the patient. This means caution has to be exerted in people with cardiovascular disease, particularly hypertension, obviously. As far as the immunosuppressing action of the steroid, well, there will be decreased wound healing, particularly because of increased infections. Keep in mind that infections are often the classic reason to have delayed wound healing by perpetuating the inflammation. And one big infection that we like to mention with people who are taking immunosuppressing drug is thrush. You know what thrush is, huh? It deals with Candida albicans, and candidiasis is very classic. As a commensal, it can start dividing and become pathological in people under immune suppression. Otherwise, high glucose is going to potentially cause formation of sorbitol and osmotic damage to the lens with cataracts. And also, corticosteroids are associated with glaucoma. For the mental dysfunction, this would require high dose, and really, as far as steroids and causing rage or aggressiveness, you're more likely to see that situation with androgens than you are with cortisol type of substances, but it's not unheard of that steroids would cause someone not to sleep well and become quite irritable. Well, this closes chapter 7 on glucocorticoids. Chapter 2 will allow us to review the drugs used particularly in peptic ulcer disease as an inflammatory disease, but it will look also at drugs used for diarrhea, constipation, so really gastrointestinal dysfunction. First, if we look at peptic ulcer disease, we're looking at a very common GI pathology, being that the primary risk factors include NSAIDs, which will be seen in that section too, NSAIDs like aspirin in particular, but also lifestyle choices such as smoking, alcohol, and certainly stress-related type of ulcers. These are drugs that are very commonly used. Most of them are available over the counter. Very few would require prescription. Here in the diagram, you see a classic for your board step 1, which is the site of action of anti-ulcer medication. What must you recognize? Well, if this is the stomach lumen at the bottom, this cell has an actual pump that pushes protons into the lumen and counter-transports potassium back into the cell. This is the famous H plus K plus ATPase, or proton pump. It is actually blocked by proton pump inhibitors, which are drugs that all end up in prazole, like omeprazole, for instance. These are currently our drugs of choice for these inflammatory stomach or duodenal disorders. Other possibility is to interfere indirectly on proton secretion by using the actual physiological control of this pump. To the far right are some of the oldest drugs used in ulcer disease. Histamine through an H2 receptor would stimulate the formation of protons. Therefore, H2 antagonists, such as the prototypical cimetidine, are going to block this receptor and indirectly prevent proton secretion. Let's not forget that vagus through acetylcholine, parasympathetic, actually stimulates muscarinic receptors which directly increase secretion such as protons. Obviously then, muscarinic antagonists of the atropine family could have been used there. These old drugs are certainly not currently used readily in peptic ulcer disease, being that they would have atropine-like side effects. Very importantly, prostaglandins have a protective role in our stomach. They not only will inhibit the proton pump activity, they actually improve mucus secretion to cover the lining of the stomach and protect it from acid erosion, and also enhance bicarbonate secretion to neutralize the actual acid. This is the main reason why NSAIDs, by blocking prostaglandin synthesis, will be associated with these ulcers. Well, there is a prostaglandin analog, which is an antidote to NSAIDs-induced ulcers. It is the drug misoprostol. You recognize prost in the name to remind you it's a prostaglandin analog that stimulates these PG receptors. Now, for pathology more than pharmacology, gastrin is an important peptide produced by both the pancreas and the gut, and it actually stimulates its own receptors, known as gastrin receptors, and exerts a nice stimulatory effect on proton secretion. Gastrin is really relevant for diseases that produce too much gastrin. There are tumors that are referred to as gastrinomas, of which Zollinger-Ellison syndrome, ZS, is a part of. Zollinger-Ellison syndrome is actually often part of multiple endocrine neoplasias type 1, together with pituitary and parathyroid type of adenomas. Unfortunately, we do not have gastrin antagonists to date, so Zollinger-Ellison syndrome will be best treated literally, supportively, with omeprazole or proton pump inhibitors. Other drugs in that diagram are not working on the parietal cells at all. Sucralfate will be a sticky gel that can coat the ulcer crater and protect it from further erosion by acids. And antacids will literally be bases that neutralize the free protons that are floating around in the stomach. So, as we look at some points about the drugs that are represented on this diagram, imagine the stem describing a characteristic of the drug and then allowing you to then place it in turn on the figure. Well, if we start with some of the oldest one, the H2 antagonist, the prototype is cimetidine, and literally, if you know that it ends up in tidine, you would know all of them, whether it's cimetidine, ranitidine, famotidine, or nizatidine. And if you want the other two, it's famotidine and nizatidine. Although, you know, cimetidine is the one that's more likely board tested, of course. They really decrease indirectly the activity of the proton pump. That is, they don't work on the pump themselves, they work on H2 receptors. Really, what they antagonize is the acid secretion that is secondary to vagal or gastrin-induced release of histamine from enterochromaffin-like cells. They have no effect whatsoever on gastric contractility, so they do not change emptying time. They are used in peptic ulcer disease in both locations, whether it's the gastric or the duodenal. Overall, they are considered less effective than proton pump inhibitors because they work indirectly as competitive blockers. And other potential uses have been GERD, gastroesophageal reflux disease, and Zollinger-Ellison syndrome. The primary issue with cimetidine family is their inhibitory effect on P450. Cimetidine is a major general inhibitor of P450. As such, it enters a multitude of drug interaction, and if you remember when we reviewed the azoles, the antifungal section in the antibiotics, well, we had explained at the time that P450 inhibition would result also in an anti-steroid effect. Well, you see this very well with cimetidine, whereby cimetidine can decrease androgen production, resulting in gynecomastia and decreased libido in males. The only other potential side effect of the drug cimetidine has been seen in the elderly, with the potential for confusion for agitation. The proton pump inhibitors, on the other hand, have supplanted the use of H2 antagonists. They all end up in prazole, and omeprazole is really the big prototypical drug. They are irreversible inhibitors of the proton pump. So not only they work directly on acid production by working on the actual transporter itself, but the fact that they are non-competitive makes them the most effective drugs we have to date in ulcer disease. They are considered more efficient than H2 blockers in treating GERD, Zollinger-Ellison syndrome, and are also part of eradication regimen for H. pylori. Do you remember in particular how we can add on omeprazole to clarithromycin, a macrolide, and add to this, or not add if not necessary, the drug amoxicillin as a penicillin. Maybe you need to tell me a little bit about why we want to treat the acid reflux that we call gastroesophageal reflux disease. I'm sure you're remembering well your pathology, that in GERD, if we chronically have inflammation of the lower third of the esophagus, we can develop an erosive esophagitis referred to as Barrett's esophagitis. In Barrett's, the lower third of the esophagus, tired of being damaged by acid injury, undergoes a metaplastic transformation. And the metaplasia is to transform those squamous esophagus, and in a graphic, the actual 1 over V as a function of 1 over S diagram, whereby I'm doing the transport through H plus K plus ATPase of my ions. If the blue represents the control curve, and if I place various curves such as A, B, C, and D on this diagram, where would you place the drug of choice in gastroesophageal reflux disease, now that you know that it's omeprazole? If it's a non-competitive inhibitor, inhibiting an enzyme is always going to be above the control curve, and irreversible inhibition would be identical to curve B, a curve that crosses the x-axis at the regular spot, but has a lower Vmax, therefore a higher 1 over Vmax. This would be the drug omeprazole. Contrast, where would you put the competitive antagonist cimetidine? Well, you would put cimetidine on curve A, a competitive inhibitor of proton pump secretion, would change the Km, but not the Vmax. So always remember those graphic formats that we review in biochemistry and that we can then use for drugs in pharmacology question. If you know this, you pretty much set as far as the two primary classes. It would be relevant that you would add that omeprazole and proton pump inhibitors are also inhibitors of P450s. As you saw in your general principles, not only cimetidine but omeprazole were classic inhibitors of the 3A4 isoform of cytochrome P450. Besides these two primary group of drugs, individual drugs that are board tested are certainly misoprostol. It is a PGE1 analog. It is cytoprotective by increasing mucus, bicarbonate secretion, and decreasing proton production. And its use is selectively when you have ulcers associated with the taking of NSAIDs, like aspirin in particular. So on your boards, it's often referred to, quote unquote, as an antidote to aspirin-induced ulcer. If you wanted to add another point about it, let's not forget that anything with prost is contraindicated in pregnancy. That is because prostaglandin analogs, of course, would induce contraction and result in abortion by triggering labor. As a matter of fact, misoprostol-like drug can be used in order to perform abortions, and certainly would potentially trigger labor unbeknownst to the person who takes it if they weren't aware of it. Sucralfate is another single agent that has been board tested for one peculiarity. It is actually a prodrug. And as a prodrug, look what it requires. It requires an acid pH before it can become a gel that can then coat the ulcer beds. Remember on the diagram, it sits on the ulcer crater itself. Well, if it requires an acid pH, it means on your exam there's a big contraindication. It is, do not use antacid with this drug. Because if you get rid of the proton, sucralfate cannot polymerize in that sticky gel. Well, it's supposed to improve healing and decrease the recurrence of ulcers. Otherwise, over-the-counter preparations such as bismuth subsalicylate, a big complicated word for Pepto-Bismol, can also bind selectively to the ulcer like a sticky gel. This is not a prodrug though. And the only reason you'll find bismuth on your exam is generally as part of a PMT regimen with metronidazole and tetracycline to eradicate H. pylori and prevent the recurrence of ulcers. Quite relevantly, people will often go to the supermarket or any Walgreens, Rite Aid, or Eckerd's in order to buy what we classically refer to as antacids. Antacids are bases that are salts, either salts of aluminum or magnesium, or carbonate salts such as calcium carbonate. Their mechanism of action is as bases to neutralize directly the protons in the gut lumen. Well, as far as side effects, surely aluminum-containing antacid causes constipation, whereas magnesium-containing antacid causes diarrhea. And carbonate-containing antacid could always be associated with alkalosis if you were taking too much of them, being that carbonic anhydrase would allow carbonate absorption. But their primary antacid could always be associated with alkalosis if you were taking too much of them, being that carbonic anhydrase would allow carbonate absorption. But their containing antacid could always be associated with alkalosis if you were taking too much of them, being that carbonic anhydrase would allow carbonate absorption. But their primary spot is in that box at the bottom here. far as your clinic is concerned, as far as estrogens go, estradiol is the major natural estrogen. If we want to supplement or use hormones that exist in the body, we need to chemically alter them to help in their pharmacokinetic, particularly to make sure that they have a long enough duration of action. So that's the idea of making synthetic form of these hormones to increase oral bioavailability, which otherwise is pretty tough for most hormones, increase their half-life. And as you use estrogen, the whole idea is to have a potential feedback inhibition of FSH and LH. Now, when you look at the estrogens, there are several forms. The natural form is actually isolated from urine of pregnant mares. It's called Premarin. That's the trade name. So they're conjugated equine estrogens. Otherwise, you'll always recognize est in the actual drug. Look, ethinyl, estradiol, mestranol, diethylstilbestrol. So you'll never have a problem, I think, to recognize this is an estrogen-like molecule. What are uses of estrogen? They can be used as a supplement in female hypogonadism. Remember, female hypogonadism could happen secondary to Turner syndrome, for instance, if you wanted a genetic form, that is. They have been used in hormone replacement therapy, HRT. And when they use in menopause in hormone replacement therapy, generally, as we'll see in a minute, it's together with progestins to oppose them a little bit. They have been used as part of the oral contraceptive pill in dysmenorrhea, in uterine bleeding. They've been used as far as acne management, and if they're used in a male, it would be at high doses in prostate cancer, but we have better drugs than this, and that would be to try and do a chemical castration, basically. General side effect of the estrogens are particularly of importance the potential of hyperplastic changes in tissue, not only in the endometrium, but certainly also in breast tissue, and that is in both ducts and lobules. You know where we're going with that, don't you? We're going to start worrying, does this hyperplasia induced by estrogen used as drugs increase the risk of cancer the same way as it does in pathology with the natural estrogens? That is the idea of unopposed type of estrogen. Well, if we turn the page, unfortunately, you bet that's what we're going to check out. The issue of thrombosis in passing is only at very high doses. Estrogens can actually cause the liver to make more clotting factors. So really, at the doses that are classically used, it's not so big of an issue unless the lady or the patient in general has a pre-existing risk of thromboembolic disease. But when it comes to the cancer risk, now that's an issue. There is now well-established increased endometrial cancer risk, and that is why we need to oppose the estrogen with progestin. Issues with the breast cancers are still considered questionable, but pathology really indicates that unopposed estrogen can increase that risk. You know that even certain surface epithelial tumors of the ovaries may have an actual link with unopposed estrogen. So as such, this is the biggest worry. Adding progestin should get rid of this potential risk of cancer. How about the story of diethylstilbestrol? Well, it is still board tested as the idea that during at-risk pregnancies, when mom was taking diethylstilbestrol, she actually ended up increasing the risk that her daughter would later on in life develop clear cell adenocarcinoma of the vagina. And that teratogenic effect, my friends, you better remember it. Classic board question of both Path and Farm. As far as other drugs that deal with the estrogen pathways, well, there are drugs that are used in cancer treatment, and these are important drugs that if you want, you could all move to your cancer chemotherapy chapter. Anastrozole is a drug that will inhibit estrogen synthesis by working on the key enzyme aromatase. Aromatase is this enzyme we find particularly in fat tissue that can take androstenedione from the adrenal cortex, make it estrone in the adipose tissue, and down the road allow the formation of estradiol. So the use of anastrozole has been to prevent estrogen synthesis and to fight estrogen-dependent postmenopausal breast cancer. The problem with anastrozole is that tamoxifen came on the market pretty much at the same time. And you know the story. Tamoxifen has become the drug for estrogen-dependent postmenopausal type of breast cancers. Before we look at tamoxifen, here's another drug that has to do with estrogen, but not cancers. It is the drug clomifen. Don't confuse clomifen with tamoxifen. Clomifen is when you want to have 20 kids in 5 minutes. It's the fertility pill. This is a drug that is going to decrease feedback inhibition of the endocrine axis, causing FSH and LH surge. Let's not forget that if FSH matures the granulosa layer, LH is the one that will trigger the ovulation and result in pregnancy. That fertility drug is undoubtedly very well mediatized as causing increased multiple birth risk. Contrast, tamoxifen, raloxifen, which are so commonly seen at the same time because they're structural analogs of each other. Well, these are part of a group of drugs we call selective estrogen receptor modulators, or SERMs. Tamoxifen is really, in a way, a partial agonist of estrogen receptors. As such, expect duality. Expect that the drug, when it is by itself in a tissue that has receptors, it can stimulate, but it will never stimulate with a maximum effect, rather with a ceiling effect, a partial efficacy. On the other hand, in presence of endogenous estrogen, it will block their action. It will behave as an antagonist. Tamoxifen then has variable actions depending on the target tissue. As an agonist, antagonist, partial agonist, we need to wonder, when am I going to use it? Where am I going to use it? It is used for estrogen-dependent breast neoplasia. It is powerful enough and safe enough as a hormonal drug to be used even in prophylaxis. You remember the major risk factor for breast cancer is to have a first-degree relative with breast cancer, that is, mom or your sister. And as such, it allows the prophylaxis, if it's estrogen dependent, a good decade prior to the onset of the actual tumor. Well, the problem with using a drug that's a partial agonist, postmenopausally, once it gets into endometrial tissue, it will behave as an agonist. And a worry has been that it might possibly increase the risk of endometrial cancers. So it's something to follow, of course. Right now, the benefits definitely outweighs the risk. But let's think in terms of the bone 1 second. A postmenopausal lady has osteoporosis, quite likely. And that was the whole basis in part of hormone replacement therapy, besides the cardiovascular risk from the high LDL when estrogens are not present. If you're a partial agonist, you should be able to prevent osteoporosis. And you don't have to say this too long for the drug companies to come up with raloxifen, another SERM that is used as a prophylaxis of postmenopausal osteoporosis. When it's used in menopause right now, there is that thought that there is no increased risk of cancer. I say to you, let's wait until there are enough decades behind raloxifen to see if this is true. The logic would be, if you're a partial agonist, you can cause some hyperplastic changes, you are just so much less likely. Look at how we can summarize this here. Both tamoxifen and raloxifene behave as agonists in the bone if you are post-menopause. Of course, all this is because of being post-menopause. In the breast, both drugs would be antagonists if the breast is an estrogen-dependent type of neoplasia. In the endometrium, well, the jury is out. It is partial agonist, therefore it can have agonistic effect. The fact that raloxifene is touted as an antagonist, I'm afraid, is because it is used for prophylaxis, therefore pre-menopause. Then of course, with the endogenous estrogen still being present, it will behave as a blocker. But wait until you're after menopause, it should behave as an agonist, just like tamoxifen. Finally, the progestins. For women here, progesterone is the major natural progestin, and it is the same rationale for using synthetic form as we saw for the estrogens. In the name, you see medroxyprogesterone, that should be fairly easy. Desogestro, you see gest for progestin. I think norethindrone is maybe the one that's more annoying. Although it has on at the end, I mean, who knows, it could be something else, so you may want to remember this one as a progestin. Progesterone is not only a progestin, remember it tends to be anti-estrogen and also sometimes androgenic, depending on the doses. You want to remember this one as a progestin. Progesterone is not only a progestin, remember it tends to be anti-estrogen and also sometimes androgenic, depending on the doses. The issue here is, what if you were using the oral contraceptive pill to treat acne in a young lady? Don't use something that would have androgenic progestins, because then of course it would worsen acne, worsen hirsutism. You see, desogestrel has this advantage that it is devoid of androgenic and anti-estrogenic activity. It is a synthetic progestin that only has the progesterone physiology. What do we use progestins for? Primarily contraception, or otherwise to oppose estrogens in hormone replacement therapy to try and minimize the increased risk of hyperplastic transformation of tissues such as the endometrium and possibly the breast. Primary effect of progestins alone is surely to increase LDL and lower HDL. This is not too good in the long run. Of course, it's okay when you're pregnant because you do need cholesterol in order to have your little baby that's growing make cell membrane, for instance. But if you're not, then obviously you have here an issue with atherosclerosis risk being increased. Progestin, with the same idea in mind of pregnancy and allowing things to grow, will cause glucose intolerance. That is, will cause a diabetic-like picture, hyperglycemia. Otherwise, we talked about the fact that it's androgenic and anti-estrogenic, so think of it as part of contraceptive pill. There is an antagonist of a progesterone receptor. It's called mifepristone, and the antagonist is used as a quote-unquote morning after pill. It's an abortive agent. It is classically used together with prostaglandin, as we know, to perform abortion. Quite unlikely on your exam, this drug. So oral contraceptives, they're classically a combination of estrogens with progestins. The whole idea is that primarily the progestin is there to suppress the mid-cycle LH surge. discharge and the ovulation. Estrogens are generally added in small micromolar range of doses in order to have a balance against the progestin and try and get rid of some of the potential side effects associated with it. You have here listed again the primary side effect of estrogen. Remember the breast tenderness, and for progestins, don't forget the weight gain, the potential for hirsutism and acne, except possibly with desogestrel, and the problem with increased LDL. Problem with oral contraceptive. They might ask you on your exam, how do they work? Generally, they want you to say decrease LH surge. But the big issue would be possibility for drug interaction. Now, that was very relevant in the chapter where we discussed anti-epileptic drug. You remember how carbamazepine, phenytoin were inducers of cytochrome P450s? And unfortunately, were also very teratogenic. But in their induction, they could actually speed up the metabolism of the oral contraception and increase the risk of an unwanted pregnancy. That has always been a board relevant point about oral contraceptive, their decreased effectiveness in presence of enzyme inducers. As far as antimicrobial that would induce, think of drugs such as rifampin, which was an anti-seizure drug that did not induce but rather inhibited the actual P450 system. Such as rifampin, which was an anti-seizure drug that did not induce but rather inhibited the actual P450 system. Saying valproic acid, perfect. Oral contraceptive and some of the myths about cancer. If the primary constituents are progestins and not estrogen, well, in effect, they are opposing estrogens as progestins, which is why they will decrease the risk of endometrial and ovarian cancer. They also decrease the risk of dysmenorrhea, endometriosis. Actually, we use them in treatment of those reverse menses. Remember the chocolate cysts in pathology, for instance? Because of the changes in pH that they cause in the cervical and vaginal area, they decrease pelvic. inflammatory disease, those potential for sexually transmitted diseases go down, and thanks to the estrogen portion, if they have it, if it's not the mini pill, they can decrease osteoporosis. So is there any tumor I should worry about with oral contraception? If you remember your pathology, there is a liver adenoma. Adenomas are benign tumors, but they're highly vascularized, and as highly vascularized tumor, if the lady is very active, they can cause some retroperitoneal bleed. The thing that is neat about these liver adenomas is that classically, if the patient stops taking the oral contraceptive pill, they tend to regress. So not a malignancy, but a benign tumor has seen an increased risk when we use oral contraception. Well, finally, let's look a little bit at androgens. And as we look at androgens, your primary androgen is testosterone and dihydrotestosterone, its metabolite. And what are the anabolizing action of these testosterone derivatives, such as methyl testosterone? Now, as you look at these derivatives, you will recognize in their name andro. And if you see andro, you know it's an androgen, like oxandrolone, for instance. They are used in male hypogonadism. For instance, tell me about this individual. You see 47XXY? And absolutely, that would be Klinefelter's, the counterpart of 45XO, the Turner female. So for male hypogonadism, it could be used for that matter. More commonly, it's been an issue for its illicit use in athletics for the anabolizing effect. Well, one problem with androgen is excessive masculinization, and if taken at a young age, the premature closure of the epiphyses, and therefore a short stature. Androgens, estrogens, progestin, they're all based on cholesterol as a structure. They're eliminated through the gallbladder. If they are, when you take too much, they can cause cholestasis, they can cause cholestasis and result in jaundice. Otherwise, it is the androgens that are generally the primary steroids to be associated with increased aggressiveness and with the potential for dependence, therefore having an actual abuse liability that is seen very much in athletes. As far as blocking androgens, there are two big reasons to block androgens. One is going to be to treat cancer, the other, BPH. Whereas flutamide is an androgen receptor blocker that is used for androgen receptor positive prostate cancer, leuprolide is the drug to know. It is a GnRH analog that is used in depot form, IM, in the butt of the patient, in order to continuously release GnRH and cause negative feedback with a chemical castration. So it's used in prostate cancer that would be advanced. Finasteride, this one is the 5-alpha reductase inhibitor that is used to prevent the conversion of testosterone to DHT in order to treat BPH. Because BPH is currently very well managed with alpha-1 antagonist, it has now been remarketed for male pattern baldness. If you're young and rubbing this on your head, your lady who's sleeping next to you might have access to it too, and she will get teratogenicity from the anti-androgen effect. So obviously here we're not talking about teratogenicity in the male. Last time I checked, males cannot become pregnant. So obviously it's for the actual partner in bed. You have the diagram showing you the 5-alpha reductase inhibition decreasing DHT and used to prevent hair loss and to decrease prostate growth. This concludes Chapter 2 on steroid hormones.
we will be discussing specifically inguinal hernias, but before we discuss inguinal hernias, let's be sure we understand what the generic term hernia means. A hernia is any time a structure that should be within some kind of a surrounding container, or some kind of a containing layer, gets out of that containing layer, we call that a hernia. Earlier in our discussion, we talked about a hernia of the nucleus pulposus when we discussed the intervertebral discs. And we said that the nucleus pulposus is surrounded by the annulus fibrosus, that's the containing wall of the nucleus. So if the nucleus gets out of the surrounding annulus, we call it a hernia of the nucleus pulposus. Similarly, if we have something that should be inside of the abdomen, contained by the abdominal wall, and it gets out of that containing wall, we would call that an abdominal hernia. And we'll name abdominal hernias according to which part of the abdominal wall they come out through. So you can have a hernia coming out through the posterior abdominal wall in the lumbar region, and then you would call it a lumbar hernia. You can have an abdominal hernia projecting upwards, we would call that an abdominal hernia. And we'll name abdominal hernias according to which part of the abdominal wall they come out through. So you can have a hernia coming out through the posterior abdominal wall in the lumbar region, and then you would call it a lumbar hernia. You can have an abdominal hernia projecting upward through the roof of the abdomen, through the diaphragm, and then you would call it a diaphragmatic hernia. If it came out the anterior wall in the umbilical region, we would call it an umbilical hernia. And obviously that means that if it comes out through the anterior wall in the inguinal region, we would call it an inguinal hernia. Now, inguinal hernias are the most common of the abdominal hernias, and therefore that's the one that we will talk about. And inguinal hernias come actually in two different types. They're called indirect inguinal hernias and direct inguinal hernias, and it's important that we understand the difference between them, because not only are they slightly different in their position, they are quite different in their pathway, in their mechanism of herniation. So we want to discuss them separately. First, we'll discuss the indirect inguinal hernia, which really is an easier one for us to understand, because if we understand the pathway for the descent of the testis, which we just discussed, then we understand indirect inguinal hernia, because it is a hernia that follows precisely the same pathway as the previously descending testis did. In other words, an indirect inguinal hernia passes into the deep inguinal ring, runs down the length of the inguinal canal, and will come out through the superficial inguinal ring, traversing the full length of the inguinal canal. So the same pathway that the testis and spermatic cord followed, that's the pathway that some visceral structure, whether it be an organ or a piece of mesentery or some fat, whatever it might be that should be inside the abdomen, will follow the same pathway as the testis previously did, coming out in the deep ring, down the canal, out the superficial ring. Which means that since it's following the same pathway that the testis and spermatic cord followed, it's going to end up in the same position as the testis and spermatic cord. In other words, it will end up in here with the other elements of the spermatic cord, which means it will end up covered by the same 3 layers of fascia that the testis and spermatic cord are covered by. The important concept to have here is that an indirect inguinal hernia is following a pathway that already exists. The inguinal canal is already there, and it's simply going into that deep ring, which is one end of the tunnel, traversing this tunnel or canal, and coming out the other end. So it's following a pre-existing pathway. That is the fundamental difference between an indirect inguinal hernia and a direct inguinal hernia. A direct inguinal hernia does not follow a pre-existing pathway. but rather it makes its own pathway on its way out through the abdominal wall. It literally tears through the abdominal wall, making its own pathway as it goes. Now, if a direct hernia is going to be tearing through the wall, making its own pathway as it goes, one might suspect that there would be no way of predicting where that's going to happen. Since it's tearing through the wall, we might suspect it could tear any place it chooses to, and we couldn't predict it. But in fact, we can predict it, because if it's going to tear through the wall, it's going to tear through the weakest part of the wall in the inguinal region. So how do we figure out where the weakest part of the wall is? Well, when we look at the layers that make up this abdominal wall, the layer that has the greatest strength is this external oblique aponeurosis layer. The external oblique aponeurosis is a very tough collagenous fibrous layer with a great deal of strength, and that's what contributes most of the strength to most of the integrity to the abdominal wall. So that means that if there's a place where that external oblique aponeurosis is deficient, where it's missing, that will be a weak spot. And we already know that there is a place where that layer is missing. We call that the superficial inguinal ring, where there is a hole in the external oblique aponeurosis. So that means at the region, at the level of the superficial inguinal ring, that's going to be a weak spot in the abdominal wall. So if a direct hernia is going to be tearing through the wall, we would expect that it would tear through the weakest place, which means it would tear from directly behind the superficial ring and tear and come out through the superficial inguinal ring, tearing its way out as it got there. Okay, so it tears through there, tears through there, tears through there, gets to there, and then it comes out the superficial ring. Now, be aware of what we just said. We just said that the direct inguinal hernia comes out through the superficial inguinal ring, and a few moments ago we said that an indirect inguinal hernia comes out through the superficial inguinal ring. So both of those statements are true. In other words, both kinds of inguinal hernias, direct and indirect, emerge through the superficial inguinal ring. What's different about them is how they got to the superficial inguinal ring. We previously said that an indirect hernia got to the superficial ring by entering the deep ring, traversing the length of the canal, and then coming out the superficial ring. The direct inguinal hernia does not go through the deep ring. It rather tears through the layers of the abdominal wall behind the superficial ring, tears through these layers, tears through that, finally gets into the canal here, and then comes out through the superficial ring. So direct and indirect inguinal hernias have in common that they both come out through the superficial ring. They're different in that indirects pass out through the deep ring. Direct hernias do not pass through the deep ring. Because the direct hernia is tearing through this layer, the transversalis layer, and it's tearing through the transversus abdominis and internal oblique layers, that means it's not going to be covered by those layers. It's tearing through them, therefore not covered by them. It will enter the canal here and exit the superficial ring, so it will be covered by the outermost layer. So in contrast to the indirect hernia, which we said will end up sitting in here where the elements of the spermatic cord are, and will be covered by the 3 layers of fascia covering the spermatic cord, the direct inguinal hernia will end up between the external spermatic fascia and the cremasteric fascia, not covered by the cremasteric and internal spermatic fascia, but only covered by the external spermatic fascia. It's not covered by these 2 layers because it tore through those 2 layers on its way out. This region where the direct inguinal hernia tears through to get into the canal, through the back wall of the canal to come out through the superficial ring, this region of the inguinal canal has been given the name the inguinal triangle, and that triangle is bounded by the rectus abdominis on the medial side of the triangle, and by these blood vessels, the inferior epigastric artery and vein on the lateral side of the triangle, and then the floor of the triangle would be the inguinal ligament. So, what we're saying here, therefore, is that indirect inguinal hernias, because they pass through the deep inguinal ring, are passing through a region that is lateral to the inferior epigastric artery. Whereas a direct inguinal hernia, because it's passing through the inguinal triangle, is passing through a region that is medial to the inferior epigastric artery. And it's that distinction, indirect hernia is passing lateral to the artery, and direct hernia is passing medial to the artery, that we can use to distinguish direct from indirect inguinal hernias. Because remember, as we said, both kinds will emerge through the same place, through the superficial inguinal ring. So, how do we use that anatomy to make that distinction? Let's imagine that at the time of surgery, we have a patient who has an inguinal hernia, and the hernia is going to be repaired by an open repair. And so the skin and superficial fascia, layers 1 and 2, are incised, which brings you down to layer 3, which is where the superficial inguinal ring is, and there's a hernial sac emerging through the superficial inguinal ring. So that tells us that it indeed is an inguinal hernia, but it doesn't tell us which kind of inguinal hernia it is. So what you can do at that time is take your finger and push that hernial sac back into the abdominal cavity. And when you push it back in, it will go back in through the same pathway that it came out. So if it's an indirect hernia, when you push it back, you're going to be pushing it back this way, and it will go back through the deep ring. And your finger, of course, will be following it, so your finger is going to be sitting here in the deep ring. The question is, how do you know that your finger is in the deep ring? You can't see that. These other layers are in your way. You can't see the deep ring. So how do you know that you're in the deep ring? Well, when your finger is there, you're going to be able to feel the pulse of that artery, the inferior epigastric artery. And what you'll say to yourself is, I can feel the pulse of the artery on the medial side of my finger, which means that my finger is lateral to the artery. We know that the deep ring is lateral to the artery, and therefore, since we know that only indirect hernias go through the deep ring, that tells me that this is an indirect hernia. On the other hand, if this was a direct hernia, when you take the hernial sac and push it back into the abdomen, it's going to go back this way, the same pathway that it came out through. That way, your finger will end up sitting here in the inguinal triangle. How will you know you're in the inguinal triangle? You can't see it, but again, you'll feel the pulsation of this artery. This time, you'll be saying the pulse of the artery is lateral to my finger, which means my finger is medial to the artery. Well, since I know that the deep ring is lateral to the artery, and I know my finger is medial to the artery, therefore I know I am not in the deep ring. And if I'm not in the deep ring, this must be a direct inguinal hernia, because direct hernias don't go through the deep ring. So it's the position of the hernial sac on its way out through the wall, lateral to that artery or medial to the artery, which will tell you whether it went through the deep ring or did not go through the deep ring, which in turn tells you whether it was an indirect hernia or a direct hernia. Now, that method, as we said, works at the time of surgical repair because we started off by incising the skin and the superficial fascia. What can we do on physical exam when we don't have the ability to make those incisions? So if we look at this slide here, we can draw into it the inguinal canal. Here's the inguinal ligament. There's the pubic tubercle, which is the medial end of the ligament. There's the anterior superior iliac spine, which is the lateral end of the ligament. And the inguinal canal is parallel to and just above the inguinal ligament, the medial half of the inguinal ligament. So the superficial inguinal ring is here, just superolateral to the pubic tubercle. The deep inguinal ring is about here, just above the midpoint of the inguinal canal. So on physical exam, you can palpate the pubic tubercle. You can then place your finger right over the superficial inguinal ring and feel for a hernial sac. And if, when you ask the patient to increase intra-abdominal pressure by coughing, if you feel a hernial sac push out against your finger, you know that that hernia is coming out through the superficial inguinal ring, which tells you it's an inguinal hernia, but it doesn't tell you which kind of inguinal hernia. What you then can do is, before you ask the patient to cough a second time, use your other hand, your non-examining hand, and compress the abdominal wall right above the midpoint of the inguinal ligament. So you're compressing the deep inguinal ring. Leaving your examining finger on the superficial inguinal ring, you then ask the patient to cough again. If the hernial sac doesn't push out that second time, since you already know that there is a hernia, why didn't it push out? It didn't push out because your compression of the deep ring prevented it from coming through the deep ring. And since only indirect inguinal hernias come through the deep ring, you've now established that this is an indirect inguinal hernia. On the other hand, if while you're compressing the deep ring and ask the patient to cough a second time, the hernia pushes out at the superficial inguinal ring and pushes against your finger anyhow, that means your compression of the deep ring had no effect on the hernia. Why? Because the hernia wasn't going through the deep ring. And if the hernia wasn't going through the deep ring, that means it's a direct inguinal hernia. So this is a different way of using the same anatomical fact, the fact being that indirect hernias go through the deep ring and direct hernias don't go through the deep ring, even though both kind come out the superficial ring. But this time you're using that fact by compression of the deep ring without having to palpate the pulse of that artery, since obviously you cannot do that on physical exam. Now, in our discussion of the descent of the testis, a layer of the abdominal wall that we did not discuss pertaining to that descent was the peritoneum, the parietal peritoneum, layer number 8. And the reason we didn't discuss it is, as you recall, the testis began in layer 7, in the extraperitoneal layer, and migrated outward. So it was already outside of layer 8, or already outside of the parietal peritoneum. So that was not a layer that was in the way, so we didn't have to deal with it. Even though that's true, there is an event relating to the parietal peritoneum that is relevant to the descent of the testis. And it's illustrated on this diagram. So here we see the testis in its initial position outside of the peritoneum. This sort of pinkish region here represents the peritoneum. The testis is outside of it. And the testis is eventually going to migrate downward into what will become the scrotum down here. This represents the pubis. It's passing over the top of the pubis through the inguinal canal to get into the scrotum. Now, even though the parietal peritoneum is not in the way, what happens is that before the testis descends, so it's not being pushed by the testis, before the testis descends, the parietal peritoneum forms an evagination, a finger-like evagination, which descends through precisely the same pathway, through that same inguinal canal, and gets down to where the scrotum is forming. That evagination of parietal peritoneum that does that is called the processus vaginalis. We see that the processus vaginalis has already descended in this picture into what will become the scrotum. The testis is still here, has not yet descended. After the processus vaginalis descends, then the testis begins to descend, and fundamentally it slides down along the outer surface of the processus vaginalis. It's not inside the processus vaginalis because it's already outside of layer 8. So it slides down along the outer surface of the processus vaginalis and will eventually work its way all the way down to where the scrotum is. Now, if that were to be the end of the story, there would be a problem. And the problem would be that we'd have this open communication between the peritoneal cavity in the abdomen and the scrotum. And because of that open pathway, it would be very easy for loops of bowel up here in the abdominal cavity to follow the same pathway and simply slide down through that evagination. In other words, it would be very easy for hernias to occur. So normally that's not where the story ends. After the processus vaginalis descends, and then after the testis descends, then the proximal part of the processus vaginalis fuses and disappears, this part. The distal part of the processus vaginalis remains unfused and is down in the scrotum. So the distal part of the processus vaginalis remains unfused, is down covering the testis in the scrotum, and takes a new name. It's now called the tunica vaginalis. And the proximal part of the processus vaginalis fuses and then disappears. So that means that the cavity of the tunica vaginalis used to be continuous with the peritoneal cavity, but no longer is continuous. So we've solved that potential problem. So that's what normally happens. But as we've said previously, during development, when layers are supposed to fuse, sometimes they don't fuse or they don't fuse perfectly. So one abnormality that can happen is we can have what's called a persistent processus vaginalis, where that last step, the fusion of the layers of the processus vaginalis, doesn't happen. The testis ends up down in the scrotum, the processus vaginalis remains patent, and so we're left with a continuous, a continuity between the peritoneal cavity and the scrotum, and that's called the persistent processus vaginalis. We said the reason that's not a good thing to have happen is that that would make it very easy for hernias to occur. And indeed, when kids are born with a persistent processus vaginalis, they are commonly born with a congenital inguinal hernia. And of course, since this is following the same pathway as the descent of the testis, those congenital inguinal hernias will be indirect inguinal hernias. So what we're saying is that congenital inguinal hernia is a result of a persistent processus vaginalis, and we're saying that congenital inguinal hernias are always indirect inguinal hernias. A variation on this theme that can also happen is that when the processus vaginalis fuses, it fuses incompletely. So we can have something like this, where this part fuses as it should, this part fuses as it should, this most distal part is not supposed to fuse, that's what remains as the tunica vaginalis, but perhaps we have a small region here that remains unfused. So you have incomplete fusion of the processus vaginalis, resulting in a fluid-filled cavity somewhere along the length of the spermatocord, and we call that a hydrocele of the spermatocord. So that would present clinically as a fluid-filled lump in the scrotum along the length of the spermatocord, a hydrocele of the spermatocord, and that, as I said, is a result of incomplete fusion of the processus vaginalis. Okay, we're now going to turn our attention to the female inguinal region and take a look at what are the similarities and what are the differences. And in short, the similarities are many. There's really only one significant or two significant differences. But the similarities are that we have exactly the same inguinal canal, we have all of the same layers of the abdominal wall, we have the same superficial inguinal ring, we have the same deep inguinal ring. What's different is what's coming through the inguinal canal and emerging through the superficial inguinal ring, and where does that structure go? So in the male, what comes through the canal and comes out the superficial ring is the spermatocord, and that of course goes to the scrotum. In the female, what comes through the inguinal canal and emerges through the superficial inguinal ring is called the round ligament of the uterus, and where that goes to is the labia majora. So we want to try to figure out why is the round ligament there and why is it going to the labia majora. What does that have to do with what we've been looking at? To understand that, we need to understand the embryology of this region. So I'm going to use this illustration that we looked at before, but use it in a somewhat different way. We're looking at an early embryo, early enough that it is not yet differentiated into male or female. So it's called the indifferent stage. So since we don't yet know if it's male or female, we don't know if this gonad is a testis or an ovary, so we'll just call it a gonad. So that's the gonad. It will become a testis or it will become an ovary, depending upon whether this is XX or XY embryo. Then, on the body wall, we see this fold of the body wall. In our previous use of this illustration, we said that this is where the scrotum is going to form, but of course we don't yet know if there will be a scrotum. And this fold is therefore called the labioscrotal fold. Labioscrotal fold, and that name tells us that if this differentiates as a male, that fold will enlarge to become the scrotum. And if this differentiates as a female, that fold will also enlarge, just not as much, and will become the labia majora. So it's called labioscrotal fold, indicating it may become a labia majora or it may become a scrotum. That relationship between two structures that have the same embryonic origin is called homologous. They are homologs. So the labia majora of the female and the scrotum of the male are homologous structures, meaning they have the same embryonic origin, just as the testis of the male and the ovary of the female are homologous structures. Next, we see this thickening of connective tissue, a fibrous band that connects the inferior or caudal pole of the gonad to the body wall at the labioscrotal fold. And to get from the gonad to the body wall, it's passing through the region that subsequently will be called the inguinal canal. And the name of this thickening of this ligament is the caudal genital ligament. The caudal genital ligament runs from the caudal end of the gonad and attaches to the body wall at the labioscrotal fold. And then we'll just add a representative structure on here to represent the arterial supply to the gonad. So this would be, we'll call it the gonadal artery. We don't yet know if it's going to be an ovarian artery or a testicular artery, but it's the blood supply to the gonad. And of course, running with that blood supply to the gonad will also be the venous drainage from the gonad, the lymphatics for the gonad, the nerves for the gonad. If this is male, that's where the duct for the gonad will run as well. Okay, so those structures are all present regardless of whether this is male or female. So we've already said that if this is male, that gonad is going to descend through the inguinal canal and end up down here. And in descending through the inguinal canal, it will drag this gonadal artery and the other vessels with it right along with it. And so the gonad will end up down here in the scrotum, and the gonadal artery and its accompanying structures will be dragged behind and will be occupying the inguinal canal, which would be in this region here, and going down into the scrotum. So in the male, the testis ends up in the scrotum, and the spermatocord, which is where the gonadal artery and vein and everything else is located, is what's coming through the canal and emerging through the superficial ring to get down to the scrotum. If this is female, the gonad, although it descends a little bit from the abdomen into the pelvis, does not descend very far. It does not descend through the inguinal canal. It remains up here in the pelvis. And so in the female, what is left in the inguinal canal is this structure, the caudal genital ligament. And in the female, part of that caudal genital ligament will end up being called the round ligament of the uterus. And so it's the round ligament of the uterus that will be coming through the inguinal canal and emerging through the superficial ring. And because in the female this becomes the labia majora, therefore that ligament will be going to the labia majora. The gonadal artery, or the ovarian artery in this case, will be accompanied by its veins and nerves and lymphatics and will remain in the pelvis within a fold of peritoneum known as the suspensory ligament of the ovary. So the ovarian artery will get to the ovary through the suspensory ligament of the ovary, whereas the testicular artery will get to the testis through the spermatocord, which has been pulled down with the descent of the testis. So the structures are fundamentally the same. The only thing that's different is that because in the male the testis descends, this structure which is represented by this gonadal artery here, is what gets pulled behind and is left in the inguinal canal. And in the female, since the ovary doesn't descend, it's this structure that's left in the inguinal canal. In the male, this structure ends up down here in the scrotum along with the testis and ends up being called the gubernaculum and is still attaching the testis to the wall of the scrotum. So in the male, the caudal genital ligament becomes the gubernaculum testis, is in the scrotum with the testis and is attaching the testis to the wall of the scrotum. So we can summarize what we've just said on this slide by saying that in the male, the gonad will become the testis, the caudal genital ligament will become the gubernaculum, the labioscrotal fold will become the scrotum, and the gonadal artery, or now testicular artery, will reach the testis in the spermatocord. Whereas in the female, the gonad will become the ovary, the caudal genital ligament will become the round ligament, the labioscrotal fold will become the labia majora, and the gonadal, or now ovarian artery, will reach the ovary in the suspensory ligament of the ovary. So the structures are fundamentally the same, their names are different, and their adult position are somewhat different only because the testis descended whereas the ovary did not. The last point to be made about this general region before we move on to the abdominal viscera is to take a look at one other kind of groin hernia. There's another kind of hernia that forms in the groin called a femoral hernia. Now, a femoral hernia presents clinically as a bulge in the groin in a location very close to where an inguinal hernia presents. Recall that we said that the inguinal canal is just above the inguinal ligament. We said that the superficial inguinal ring is right about here. And we said that all inguinal hernias emerge through the superficial inguinal ring. A femoral hernia emerges in this region here through what is called the femoral canal. Now, the femoral canal is an evagination of fascia. The femoral sheath is an evagination of fascia, and that femoral sheath covers the femoral artery and femoral vein and a space without any significant structure in it called the femoral canal. So what's happening is that as the blood supply to the lower limb passes under the inguinal ligament, evaginating the transversalis fascia as it does, that evagination of fascia is called the femoral sheath. The femoral artery and vein, which are the continuations of the external iliac artery and vein, do not occupy that entire femoral sheath. There's a little extra space. That space is called the femoral canal. And abdominal viscera can emerge into that femoral canal and present as a bulge here. Here will both present as a bulge in a location very close to the abdomen called a femoral hernia. Now, a femoral hernia presents clinically as a bulge in the groin in a location very close to where an inguinal hernia presents. Recall that we said that the inguinal canal is just above the inguinal ligament. We said that the superficial inguinal ring is right about here. And we said that all inguinal hernias emerge through the superficial inguinal ring. A femoral hernia emerges in this region here through what is called the femoral canal. Now, the femoral canal is an evagination of fascia. The femoral sheath is an evagination of fascia, and that femoral sheath covers the femoral artery and femoral vein and a space without any significant structure in it called the femoral canal. So what's happening is that as the blood supply to the lower limb passes under the inguinal ligament, evaginating the transversalis fascia as it does, that evagination of fascia is called the femoral sheath. The femoral artery and vein, which are the continuations of the external iliac artery and vein, do not occupy that entire femoral sheath. There's a little extra space. That space is called the femoral canal. And abdominal viscera can emerge into that femoral canal and present as a bulge here. So the point that I want to make here is that a femoral hernia, which presents here, and an inguinal hernia, which presents here, will both present as a bulge in the groin very, very close to one another. And the distinguishing characteristic that separates inguinal hernia from femoral hernia is that inguinal hernias exit above the inguinal ligament, with exit below the inguinal ligament where the femoral canal is.
Spanish process also. Wait. What it is? Full definition. Spine. First. Konuşma birisinin adı ne? Concept. Several konuşmalar için dolaşıyor. Okay. Okay. This is called like okay. Usually in the experience. Okay. Let's see. Head to the side. This section is not fix. When you press button, Small minded. Point of tubercle. Symphysis still. This is symphysis. This is tubercle. In fact, the means is more than detail. segment. Okay, teaching supply available. Yeah, it's okay. Extra, yeah, yeah. 일요일로 이제 먼저 좀 Total number of pennies. Branch of pennies. Okay. Perennial branch. Next is parasite. Pennies. Okay. Perennial. Branch. Okay. 6. Let's do S3 S4. Let's do email better way. Let's do search. So is better computer through. Okay, let's see. Different. Then this is what I need to do. Finished. It's kind of interesting. So battery at Akkor giovedì guarda il cliente perché non so penso. Non so adesso pure una vacanza, pure una vacanza di questo. Se non so la cliente, non so per il pranzo, per il Recreation is being possibly Scottish monster. Più radio e sempre come se più radio tutto per uso più chiesa più Ah, here. Understand. So that you covered the total problem. Equator 2500 covered out the city. Nice. Ready bit rate. Output media object. This is storage. Okay. Flat. Nice. Okay.
The testes is one of the greatest designs created by Mother Nature. It's simple, comes in different colours and sizes, and is available to all with a Y chromosome. This handheld device has been perfectly engineered to maintain complete thermoregulation. Production starts with the testes. Wrapped in the tunica vaginalis, a pouch of serous membrane derived from the peritoneum. This is both visceral and parietal components. The first milestone to achieve was getting the testes to pass through the deep inguinal ring, taking with it internal spermatic fascia from the transversalis fascia. The internal oblique came next, out of which the cremaster muscle and its fascia were created. Its intuitive design allows raising and lowering of the testes to create the perfect environment for spermatogenesis. The final landmark that gave us the breakthrough was the superficial inguinal ring. Here we took the external spermatic fascia from the external oblique.
I'm going to 6 months before I would do that. School starting need. Okay. Check what I the other side. Can external transport center number. That's it. Zero. 366 890. Smells good. Cool. 11 o'clock. Experimented. Kidney, first major. This is first major kidney, and this is okay. 10, 90 responsiveness, approaching 90. Resolution just okay, 90 to 92. Dun, 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 dun. For example, let's do more so about so that more so by even with the and that is two notes. The ABCD. एक बार को ये इस पर कर लीजिए सीधे अपने को आंसर का okay you see right so far you see I think the position you need not take the distribution speaking Tremendous speaking points and digestion. It's on Spain. Okay. Got it. It's not about the flag, it's about the city. City doctor. Doctor is not stop. Content right at the doctor. Content time to for our staying. Please.